Okay. After falling from a horse during a during a steeplechase. What does it mean? Okay. During a steeplechase, a 42-year-old man has immediate paralysis in all of four extremities and has loss of sensation below the clavicles bilaterally. On examination by paramedics, he is alert, dizzy, unable to move his extremities and trunk. His pulse is 98 per minute, respiration at 28 per minute, blood pressure 150 by 90 millimeter of mercury. After transport to a trauma center, his sensory examination returns to normal. He regains normal strength of arms and forearms, although the hands and the lower extremity remains weak. Examination shows bladder distension. MRI of the cervical spine show contusion. MRI of the cervical spine show contusion with edema of the spinal cord at the cervical 3 and 4 levels, C3 and 4. Plain X-ray of the cervical spine show non-displaced fracture of the vertebral body of C3. Which of the following is the most appropriate next step in the mention?
Ready?
Yes, yes,
Sorry. Yeah. Can you see my can you see my screen?
yes, yes.
Okay. Okay. So it's IV
I
methylprednisolone
sometimes
therapy.
hide your screen because uh, sometimes
Yeah.
I
Mhm.
like I try
So
to
you can
steal your
answer.
answer.
Yeah, yeah, yeah. No, you do good. Yeah, you did good. So you don't because
That
it helps
that's
me.
that's why
Yeah.
I asked because you are giving answers and
Uh-huh.
it is
Uh-huh.
it is the subconscious mind of us
Yes.
like to
Yes.
steal others' answers.
I get it. I get. I get it. Spinal cord compression can occur in the setting of trauma, malignancy, with vertebral metastasis and infection, like epidural abscess. Its presentation depends on the level of lesion and the degree of spinal cord compression. Traumatic spinal cord injury typically caused by fracture or dislocation of the vertebra. Acute traumatic spinal cord injuries typically cause immediate compression of shearing of the spinal cord, with a secondary injury of the spinal cord occurring after the initial injury. Because of consequent inflammation, edema, ischemia. Symptoms include back or neck pain, flaccid paralysis, numbness, bowel or bladder incontinence, retention, hyporeflexia. Patients may also develop neurogenic shock depending on the level of injury, with bradycardia and hypotension secondary to injury to the sympathetic outflow tract, as well as respiratory failure caused by diaphragmatic paralysis. Diagnosis is classically made using MRI of the spine as well as X-rays and CT to visualize skeletal deformities. Management include clinical stabilization and the use of IV steroid therapy to decrease spinal cord edema. Okay. Patients may also require intubation and mechanical ventilation, vasopressor support, cardiac pacing, and surgical spine stabilization. It's not B. IV labetalotherapy is used hypertensive urgency and emergency, which present with increased BP, typically with systolic greater than 180. And endorgasm is characteristic of hypertensive emergency. This patient BP is near normal and does not require correction. Okay, 190.
Okay, next. A 47 a 47-year-old man is brought to the 47-year-old man is brought to the emergency department by police after he was found in a state of confusion outside a convenience store He feels he feels anxious. He has not had fever, headache, abdominal pain, nausea, or vomiting. He has 3 year history of uncontrolled. He has 3 year history of uncontrolled hypertension. He has no allergies and takes no medications. He has not smoked and usually drinks 12 to 14 beers daily. He says he has never used a illicit drug. He is disheveled and agitated and picks an imaginary things in the air. He is oriented to the person, place, and time. Temperature is 37.5 degrees Celsius. Pulse is 110 per minute. Blood pressure 160 by 105. Examination showed diaphoresis, tremulousness. There is seborrhea and rosacea of the face. There are no signs of head trauma. The neck is supple. There is diffuse hyperreflexia. Babinski sign is absent bilaterally. Babinski sign is absent bilaterally. Which of the following is the most likely diagnosis?
Ready?
Sorry,
Ready?
1
Sorry.
minute. Okay,
Okay, so it's delirium tremens. This patient has developed delirium tremens, a serious complication of alcohol withdrawal. Alcohol increases the CNS activity of GABA. Abrupt discontinuation therefore leads to sympathetic override, and complicated alcohol withdrawal typically presents with tremors, anxiety, restlessness, diffuse hyperreflexia, headache, nausea. Theraphoresis, which can occur hours after stopping alcohol use. Delirium tremors, the most concerning life-threatening complication, involves severe confusion and disorientation, fluctuation in consciousness, agitation, visual hallucination, autonomic instability, uh, variable heart rate, BP with hyperthermia. Delirium tremors typically begins like 2 to 5 days after patient last alcoholic drink. Delirium tremors is managed supported with benzos to address the psychomotor agitation and prevent worsening. Management also includes fluid resuscitation, notation of supplement, and frequent assessments for vital signs. What else was I? Oh, maybe D. Yeah. Cocaine intoxication present with euphoria and increased sympathetic thought manifested as tachycardia, hypertension, pupillary dilation, and restlessness. Hallucination may occur, though disorientation is not consistent with delirium. This patient endorses alcohol, not cocaine use. Okay.
okay. So in that for treatment of delirium tremens, we will give benzos,
Mm-hmm.
and delirium tremens can come with like hyperreflexion. Babinski sign is absent. Both upper and lower motor neuron type of thing, or is it? Or we should not look at those signs in this
No, don't
case.
look. No, don't look at those. So I think the main thing in delirium tremens is the visual hallucination.
Okay,
So everything is sympathetic. So anxiety, blah blah blah, tremors, blah blah blah, plus the visual hallucination. If you get all of that without the visual hallucination, I'm thinking it's just alcohol intoxication.
okay.
Yeah. I mean, sorry, it's just alcohol withdrawal. The normal.
Delirium tremens. Okay.
Yeah.
A 6-month-old boy is admitted to the hospital for evaluation of spasm. The child's father and paternal aunt are mildly retarded The child's father and the paternal aunt are mildly retarded and have seizures. The father has cuneiform lesion on his cheeks but without comedons. Examination of the patient shows 5 1 to 2 centimeter depigmented areas of the chest and flexor surface of the upper and the lower extremity. A CT scan of the head show subependymal calcification near the foramen of the Monroe of the left. A CT scan of the head shows subependymal calcification near the foramen of the Monroe of the left. Which of the following is the most likely diagnosis? Subependymal. Subependymal.
Ready?
Yes. Is it tuberous sclerosis?
And that's what I picked. Let's see. Yeah, it's tuberous sclerosis, autosomal dominant neurocutaneous disorder characterized by benign tumors in several organs. Hematomas can form in the soft tissues, leading to chagrin patches of subcutaneous oval nodules, or brain, leading to epilepsy, intellectual disability, cardiac rhabdomyomas, leading to mitral regurg, and renal angiomyolipomas.
Mm,
Other typical dermatologic findings include Ashley spots, hypomelanotic macules, and angiofibromas, which are acneiform lesions without comedons. Plug help. So pentendema giant cell tumors are common, which typically demonstrate calcification and may increase the likelihood of developing seizure. Though these tumors are benign, the patients are at risk of developing malignancies in the soft tissue, brain, and kidney. Diagnosis is typically clinical but may be confirmed by genetic testing indicating a mutated TSC gene. Management requires anticonvulsant medication for seizure, surgical resection, or rapidly growing or symptomatic tumors. It's not NF neurofibromatosis, neurocutaneous disorder. Type 1 presents with cutaneous neurofibromas, benign neoplasm derived from neural clusters, cafe or less spot, pigmented leaf nodules, optic gliomas, and pheochromocytomas. Type 2 presents with cutaneous neurofibromas, also bilateral schwannomas, additional intracranial meningiomas, neuropathy. So, yeah. It's not Sturge-Weber. Sturge-Weber neurocutaneous disorder also presents with proliferation of capillary-sized blood vessels seen on exam as nevus flammeus. Benign birthmark, also known as Paul Weinstein. Angiomatosis of the leptomeninges leading to seizure, intellectual disability, blah, blah, blah. In episcleral hemangioma, the causative active mutation is the GNAC gene and is sporadic rather than inherited. Torch syndrome refers to fetal infection oh, by any of the group of organisms like Toxoplasma, Rubella, CMV, herpes, blah, blah, blah. And then, yeah, no. Next.
okay. Okay. Next. Sorry. A44. A44. Sorry. A 62-year-old man comes to the physician. A 62-year-old man comes to the physician because of 4-month history of progressive difficulty of climbing stairs. 4-month history of progressive difficulty of climbing stairs. It is generalized muscle pain, progressive difficulty of climbing stairs, generalized muscle pain, dry mouth. He has hypertension, type 2 diabetes, mellitus, hyperlipidemia. Current medication include atorvastatin, atenolol, glyburide. He has smoked 2 packs of cigarette daily for 30 years at least. At last visit 6 weeks ago, X-ray of the chest shows a solitary lung nodule. X-ray of the chest show a solitary lung nodule. Today his pulse is 80 per minute, respirations are 14 per minute, blood pressure 136 by 82. Examination of the lower extremity show bilateral proximal weakness and hyporeflexia, bilateral proximal weakness and hyporeflexia. EMG and nerve conduction studies show incremental increase in amplitude of the evoked motor response. Which of the following is most likely to have prevented these symptoms?
Ready?
Wait. Is it Eaton-Lambert syndrome?
That's what I'm thinking.
Eaton-Lambert syndrome associated with small cell lung cancer, isn't it?
Yeah.
Smoking cessation. Okay, let's see.
Yes, smoking cessation. Lambert-Eaton myasthenic syndrome is a uncommon neurologic condition that affects neuromuscular junction transmission. Normally, action potential leads to depolarization in the terminal button of the axon. Voltage-gated calcium channel consequently open and allow calcium influx, which triggers exocytosis of the neurotransmitter field vesicles into the synaptic place. Patients with LEMS possess antibodies to voltage-gated calcium channel on presynaptic lower motor neurons, which decreases calcium inflows and the subsequent release of acetylcholine. This patient with a smoking history and proximal muscle weakness with an lung nodule likely has paraneoplastic autoantibody production against voltage-gated calcium channel, causing LEMS. Patients may also have depressed or absent dependent reflex. The muscle weakness typically improves with exercise as small amounts of acetylcholine accumulate in the synaptic cleft over time, increasing the frequency of postsynaptic action potential in skeletal muscle. This can be seen on nerve conduction study as well. Autonomic symptoms such as decreased salivation, uh, which causes dry mouth, may also occur. The diagnosis may be confirmed with nerve conduction studies and electromyo, whatever, with exercise testing. In these patients, smoking cessation would have prevented the lung cancer in the lungs. Next.
Okay. A 30-year-old construction worker comes. A 30-year-old construction worker comes to the physician because of constant mid-lower back pain. Constant mid-lower back pain for a month. He has no leg pain. SLR causes discomfort only in the lower back. Sensory motor examination is normal. Which of the following is the most appropriate next to management?
Ready?
Yes.
So it is restriction of heavy lifting until the pain resolves and instruction in proper body mechanics. Okay. Low back pain is common condition that is self-limited for many individuals. There are many causes of low back pain, and it really can be caused by serious illness that requires medical treatment or surgical intervention. Risk factors for low back pain include strain of swell, heavy lifting, trauma, obesity, age. Most patients present with lumbosacral strain caused by heavy lifting or extended periods of sitting. In patients with history of trauma or osteoporosis, vertebral compression fractures, or other vertebral fractures are a consideration. Signs and symptoms that increase the risk of an urgent medical or surgical cause of low back pain include a fever, focal midline spinal tenderness, weight loss, pain Increase at night, focal neurologic syndrome, urinary incontinence or urinary retention. In this patient with no sensory motor abnormalities, mostly because of his upper is lumbosacral strain from heavy lifting. She's a construction worker. Most patients with lumbosacral pain will improve within 4 weeks with short-term symptomatic therapy, including pain control, restriction in heavy lifting, and restriction of heavy lifting and pain control, physical therapy, and instruction on proper body mechanics. Prolonged periods of inactivity and bed rest should be avoided. It's not D or E. Epidural injection of steroids and NSAID will also be inappropriate prior to period of physical therapy and restrict heavy lifting. Typically, physical therapy and rehab are sufficient to treat lumbosacral stent in majority of patients. It's not E. If IBD's excision and fusion will only be appropriate in the setting of this herniation, causing severe pain and functional limitation despite a trial of physical therapy. In some cases, this herniation can cause acute onset neurologic deterioration from spinal cord compression called Acuña syndrome, which require emergent surgical management. This patient does not demonstrate any signs of neurologic dysfunction. Next.
A 32-year-old man comes to the physician because of 6 month history of deep 6 month history of deep arch deep deep aching neck and shoulder pain, deep aching neck and shoulder pain, and progressive weakness of his hands and poor coordination. 2 years ago, he had a whiplash injury. 2 years ago, he had a whiplash injury that resolved without treatment over a 3 month period. Neurological examination shows hyporeflexia of the upper extremity. Neurological examination shows hyporeflexia of the upper extremity. He has atrophy of the intrinsic muscles bilaterally. He has atrophy of the intrinsic muscle bilaterally. There is asymmetric decreased strength of grip and finger abduction and extension. There is asymmetric decreased grip of finger abduction and extension. Sensation to pinprick is decreased over the upper torso and the shoulder. Which of the following is the most likely cause of this patient's finding? Hyperreflection, the sensation to pinprick is decreased. Still,
Ready? Ready?
wait 1 second.
Mhm.
Light investigation. Okay.
So it's syringomelia. Syringomelia refers to progressively expanding cystic lesion involving midline spinal cord structures, most commonly in the cervical or thoracic spinal cord. Syringomyelia may be associated with congenital malformation such as Chiari malformation type 1, spinal cord infections, autoimmune disease such as MS, neoplasm, and spinal cord trauma. Syringomyelia typically compresses spinothalamic fibers, decusating in the anterior commissure. So that would be the pain and temperature. Okay. Consequently, patients present with deficits in pain and temperature sensation in the bilateral upper extremities and torso. Since the ascending sphenothalamus in the lateral cortex are unaffected, sensation of the lower body is intact. Okay. Neuropathic pain in the upper extremities may also occur. The lesion may expand to compress the bilateral anterior horns, the location of the cell bodies of the lower motor neuron. Therefore, patients may present with lower motor neuron pattern of dysfunction in the bilateral upper extremity, decreased muscle tone, hyporeflexion, early atrophy. The cyst may progressively expand to compress the lateral corticospinal tract, in severe cases leading to upper motor neuron pattern dysfunction in the lower extremity. Okay, so it's not anterior spinal cord syndrome. Results from ischemia of the anterior spinal artery by thrombosis or trauma, leading to damage to the corticospinal, spinothalamic, and autonomic tract. The syndrome manifests with loss of pain and temperature sensation, that would be spinothalamic, motor function below the level of the region, um, along with autonomic dysfunction. Okay. Syngomalia causes loss of pain and temperature sensation localized to the upper extremity, and autonomic dysfunction is uncommon in syngomalia because of, yeah. It's not posterior cord syndrome, results from ischemia of the posterior spinal artery leading to ipsilateral DCML damage. These patients present with ipsilateral sensory of proprioception, fine touch, vibration below the level of the lesion. DCML that is unaffected in syringomyelia. Brown sequence, a midsection of the spinal cord, damage of the anterior horn along with the corticospinal tract, DCML, and spinothalamic. Patients typically present with contralateral impairment in pain and temperature, ipsilateral deficits in other sensories, and ipsilateral upper motor pattern of dysfunction below the level. DCML tag is typically unaffected in syndromalia.
Okay.
Mm-hmm.
A previously healthy 13-year-old girl is brought to the emergency department after an after a generalized tonic-clonic seizure that occurred at school. Her teacher noted that the seizure was preceded by jerking of the right arm. The seizure was preceded by jerking of the right arm. She had a similar episodes 8 months ago. She had a similar episodes 8 months ago. Examination at that time showed no abnormality. No treatment was begun. She was born in Mexico, and she and her parents made occasional trips to local rural Mexico. Their visit was 2 years ago. She was lethargic on arrival to the emergency department, but she is now awake and alert. Temperature is 37, neck is sharp, neurologic examination shows no abnormal, leukocyte count is 6,400. CT scan of the head is shown. Which of the following is the most appropriate screening test for family members of this patient? Screening test for family
Ready?
Yes.
So it's examination of the stool and oval for parasite, neurocysticercosis, CNS infection caused by Portenia solium that occurs most commonly in endemic rural region of Latin America, Asia, and Africa. Symptoms include headache, seizures, signs of increased intracranial pressure, and rarely altered vision. Some patients are asymptomatic, while others may present with muscle and subcutaneous nodules. Typical manifestation on CT MRI includes cystic ring enhancing lesion, um, cystic ring enhancing calcified lesion in the brain parenchyma, meninges, ventricles, spinal cord, and or orbit. Scolex larval head may also be demonstrated on imaging. Treatment includes symptomatic management of increased intracranial pressure and seizures, antiparasitic therapy, and or steroids. As this patient has primarily traveled with her family, they are similar at increased risk for neurocysticercosis and should be screened for the infection with examination of the stool and ova for parasites.
Okay, next. This one is bit hard. Just cannot be identified just looking at the picture. You can
Mm-hmm.
guess the answer,
Mm-hmm.
but you can't guess the specific, like
From the pic.
neurocysticercosis.
Yeah.
Okay, next. A 6-year-old a 6-year-old girl is brought to the physician because of 1 week history of progressive weakness and numbness of the leg. This morning she has an urinary incontinence, 6-year urinary incontinence. 1 year ago, she underwent resection of a medulloblastoma and placement of VP shunt for residual hydrocephalus. Her post-operative course has been uncomplicated. Currently, she is drowsy and irritable. Her temperature is 37.5 degrees Celsius. Pulse is 82 per minute. Respiration at 24 per minute. Blood pressure 126 by 54 millimeter mercury. Fundoscopy examination shows no abnormality. Examination of the lower extremity shows weakness and diffuse sensory loss. Deep tendon reflex are decreased. Which of the following is the most likely mechanism for this patient?
Ready?
Okay,
So it's metastatic spread of the cancer through CSF. Metastatic spread of the cancer through CSF pathway is the mechanism behind the patient's development of cardiac syndrome. Cardiac syndrome occurs as a result of compression of the spinal nerve roots comprising the cardiac. Often such compression occurs because of malignancy, as in this case, trauma, disc herniation, spinal stenosis, spinal epidural abscess, or spinal epidural subdural hematoma. Symptoms include lower extremity numbness, weakness, paralysis, hyperreflexia, perineal anesthesia, fecal incontinence with rectal tone, overflow incontinence, marked by inability to void with associated urinary retention. Emergency MRI of the lumbosacral spine is indicated to investigate the cause of cardiac syndrome and to determine the necessity of surgical decompression. Initial treatment for patients with epidural spinal cord compression and neurologic deficits include symptomatic treatment, pain control, and steroid therapy given prior to surgery. High dose steroid therapy is helpful as a bridge to definitive therapy and may improve the neurological function by decreasing edema of the spinal cord at the site of spinal cord compression. Next.
so how you pick that metastatic spread of cancer through CSF pathways?
She had cancer before,
Yes, okay.
so yeah, so metastatic,
So
and then
why not hematogenous?
because I don't know, it's not usual that you will see the cancer, the metastasis
Cancer,
imagenesis. Like I mean, I'm not saying when I say usual, I mean on the questions on MBME. I'm not saying like in real life. I'm saying on the questions on MBME is usually like
Metastatic
uh,
spread usually not hematogeneously through other pathway like
in
CSF.
the yeah, no, it's not usually hematogenous. Um, okay, and I picked CSF because I know it has something to do with the spine. Like I already knew it was Cauda equina based on the symptoms that she was having, like the the urinary issues, the
Bowel bladder involvement,
yeah,
there may be
incontinence, chronic,
hyporeflexia,
yeah,
sacrum,
so you already
lumbocervical,
know,
spinal
yeah, so you already know
root
it's affecting,
involvement.
so you already know it's affecting the spine based on that. So why would you pick hematogenesis? Like if it's affecting the spine, most likely CSF. That's kind of why I went to it.
Okay, next.
Uh, my other option was like the superior sagittal sinus because that may have, but they
Superior sagittal sinus thrombosis, like that one.
that would, yeah, because that would make us like I guess some of the pathways that go from the brain to the they make us that, but then they put their fundoscopic exam shows no abnormalities, and then this will cause like increased pressure in the brain, so it will cause fundoscopic issues. So that's why I didn't go with that. I think that was the only thing that was confused.
Okay. A 45-year-old woman. A 45-year-old woman is brought to the emergency department 30 minutes after a generalized tonic-clonic seizure. Tonic-clonic seizure 1 minute. She had a headache 6 hours ago. Nausea and vomiting for 2 hours ago. She has no history of seizure and has no medication and had no medical problems other than hypertension. Treated with enalapril hydrochlorothiazide. Her temperature is 37.2 degrees Celsius, pulse 100 per minute regular, respiration is 16 per minute, blood pressure is 230 by 140 millimeter of mercury, 230 by 140 millimeter of mercury. She appears drowsy but is responsive to commands. The examination shows no abnormalities other than fundoscopic findings shown. Which of the following is the most appropriate initial pharmacotherapy?
Hmm, it's tricky. She has
Is it hypertensive
hypertensive.
emergency, isn't it? And
Yeah,
there is, it looks like papilloedema.
yeah, yeah, I guess that. Ready?
Okay.
So it's neutropathy. I was between that and furosemide, but okay. This patient presented signs and symptoms of hypertension, tachycardia, altered mental status, seizure, optic disc edema are consistent with diagnosis of hypertensive encephalopathy. May result from acute or severe increases in BP and may manifest with headache, vomiting, agitation, altered mental status, seizure. It may progress to coma. Visual symptoms may result from cortical hypertension or from hypertension retinopathy. Retinal findings may include optic disc edema and nerve fiber layer infarction or hemorrhage. Treatment includes carefully lowering the BP while avoiding excess drop in BP, which can, yeah. In general, a decrease 25, blah, blah, blah. Sodium nitroprusside is a potent vasodilator and is preferred agent because of its very short half-life, allowing it to be treated via IV infusion. It is not furosemide, oral IV loop diuretic. Diuretics are not typically used in the treatment of hypertension emergency because of the comparatively long half-life and duration of action. Okay, next.
A 42-year-old woman comes to the physician because of 4-day history of progressive weakness and numbness in her legs and blurred vision and discomfort in both eyes. She has no history of serious illness, had no take no medication, vital signs is 20/80. Bilateral examination shows bilateral optic disc. Examination shows bilateral optic disc edema. Muscle strength 5/5, upper extremity 4/5, lower extremity deep tender reflex upper extremity, and 4 in lower extremity. Babinski sign is present bilaterally. Lumbar puncture is performed where glucose is 80, total protein 105, WBC 50, RBC 5, oligomer 0. MRI of the brain show periventricular white metal lesion, and MRI of the thoracic spine showed an abnormal T2 signal and mild enhancement within thoracic cord spanning T3 to T6. Which of the following is the most likely to be noted for further testing in this patient? Is it MS?
Mm, mm, I don't know. You say ALS?
I say MS.
MS. They
Is
said
there any
something.
possibility of happening MS?
I thought MS oligoclonal antibodies should be there. Shouldn't they?
Yes, oligoclonal band should be present.
MS.
It's not like Wilson disease, isn't it? And there is no rollover echo. What? There is
No.
optic disc edema like optic neuritis or optic problem. MS can
Mm-hmm.
come with. Is it neuromyelitis optica?
What? I never heard about that one. I never heard about that one. Case peripheral nerve conduction. Um, yeah, I think it's MS. Not the MS, the other one. The
Which one?
maybe the yeah, maybe not. No, maybe I'm wrong. No, maybe you're right. It's M. But MS, why would they have? Okay, I guess let's go with MS. Ready?
Yes.
Yeah, it's MS. Oh, that's why you would neurolog. I didn't even know. I never heard that. I was like, I never heard that word before. Aquaporin 4 antibodies in the CSF are diagnostic of neuromyelitis optica. The fact that you remember the word is crazy. A disease characterized by intense inflammation and demyelination of both the optic nerve and various spinal cord segments, with involvement of both gray and white matter. Common manifestations include episodes of optic neuritis, which manifests as vision loss and pain, and transverse myelitis, which can affect any level of the spinal cord. Other unique findings include episodes of hiccups with associated nausea and vomiting. The disease course is often described as relapsing and remitting, with some patients experiencing few symptoms between episodes. Treatment is with high dose IV steroids, occasionally plasma exchange for acute attacks. Prophylaxis with eculizumab and other biologic agents is warranted at the time of diagnosis. Hmm. So what
Okay.
is it? Is it like
Sorry.
a antibodies against like
Anti aquaporin 4 autoantibody, like aquaporin antibody against aquaporin 4.
so kind of like a variation of MS?
Yes.
Okay.
Neuromyelitic optica share some clinical feature of MS, like optic neuritis and myelitis, but it has some severe form. Neuromyelitis optica has another, um, what can I say? It has some extra features also in NMO. And for NMO, like neuromyelitis optica, to be told via MRI, there may be in here they have written in a very narrow manner, like MRI of the thoracic spine show abnormal T2 signal. There is signal change, abnormal T2 signal, and mild enhancement within the thoracic spanning 3 to T3 to T6. So there is big, like T3 to T6, more than 3 spinal cord segment. If there is any MRI, in any MRI, there, if there is signal change more than 3 or more than 3 spinal cord segment and positive aquaporin 4 autoantibody, it is NMO. You got my point.
Mm-hmm.
Like in the MRI, more than 3 spinal segments should be involved. In here, T3 to T6 spinal segment is involved along with mild enhancement and signal change. And
Mm-hmm.
there are some features of IMS like optic neuritis, myelitis, but this has more aggressive course than the normal multiple sclerosis. We know that multiple sclerosis has relapsing remitting feature, but the NMO is more progressing than the what can I say, multiple sclerosis. You got my point.
Got it.
Am I talking too much complex?
No,
Okay,
no. Mhm.
because
Oh,
sometimes when I try to explain you, I don't know actually what I am talking about.
ah, no, I got it. I think I get the main points.
Okay,
I get. Okay, we are done. We can take a break before we
okay,
start near 7.
okay. Bye bye.